In January of 2013, BPS issued a white paper outlining a 5-year vision. Why don't you talk a little bit about what was in that white paper?
Well, this was an important paper for us to publish because we felt we had to convey to the public at large, to our stakeholders in pharmacy, to our stakeholders in medicine, where we were headed, and we are moving very rapidly. So we needed to answer some questions, put some context around that, set some goals. So the goal of 30,000 board-certified pharmacists by 2017 was articulated in that white paper, driven largely by the extent that we know we need at least that many or potentially more to meet the needs of patients. So that was a pretty straightforward goal. But one of the statements that we made that was important, a couple areas. We tied future, because I get this question all the time, say, well, what's the next specialty? And I tell folks, I think if you look at the evolution of PGY2 residencies, the specialty residencies, that will give you some insight as to where the next specialties could come from. And so we just made the statement that we think future specialties should be tied to the availability of PGY2 residencies that are accredited by ASHP. We have a caveat that there may be exceptions to that, but generally that's the direction that we should move. And again, it speaks to that alignment that we think we need in the profession to have a reasonable approach. The other commentary we made, which is really important in this white paper, is we broached the idea of subspecialties. Again, this was talked about in 1974 as a possibility. I think it's taken a while to obviously build the infrastructure, and my predecessors, Sam Kalm and Dick Burton, did an amazing job in building a strong infrastructure that's allowed us to continue to grow. And so we're now think it's time to visit the idea of should we create a subspecialty process. And we put out in the white paper that we believe the model could draw parallels to the American Board of Medical Specialties. ABMS has 24 member boards, so it's 24 specialties, and they have about 140 subspecialties. Now, we're not proposing 140 subspecialties. It might not even be 24 specialties, but we think the concept of a primary board certification is important because the pharmacist knowledge, and this is where we think the pharmacist value equation differs than the medical specialist. The pharmacist has a broad and deep knowledge of therapeutics, and we think that's extremely valuable, and we don't want to lose that by becoming so specialized. And anecdotally, I have pharmacists that are board certified say they draw on their general medication knowledge to resolve issues that are not directly in their specialty area but impact the patient, that have to be resolved, and the medical specialists come to them. So, for example, and I think we use this example in the white paper, the board certified psychiatric pharmacist treating a patient with acute depression because of a chronic disease like diabetes. A lot of times you've got to get that chronic disease under control like diabetes before you can get to the other issues. And so we think that value proposition of pharmacist knowledge and skill being broad-based is important, and we want to maintain that in our board certification structure. So we propose a series of primary specialties. The profession will enter into a dialogue and decide what that looks like and decide if this parallel with ABMS makes sense. We think it does, but we'll vet that both with pharmacy and even medicine and nursing to see what their thoughts are. And then the idea would be that if someone earns a primary certification in a specialty area, and we think that the specialties we have right now are pretty well set up to do that. When you look at broad specialty areas like oncology and pediatrics and ambulatory care and pharmacotherapy, it could lead very easily to a model where then you could have some subspecialization underneath that. So that was important that we put that out on the table. And I don't know, we'll try to decide that over the next, 2 to 4 or 5 years. So that we know going forward where all these things fit and what should be a specialty or what might be considered a subspecialty. So we've got to develop those criteria. So that was important. The other, a couple other points we made in the white paper is we did comment on international pharmacists seeking certification, and committed to a task force to start to look at those international issues. It's pretty apparent, I think, to many of us on the BPS board that the world is a lot smaller place. And we're a regular participant in the FIP meetings, and we're seeing that, and we're seeing a lot more global dialogue about pharmacist education and training. And so we want to make sure, and interest in board certification, as we see by the numbers, so we want to make sure that we're sensitive to those needs and that we work through those issues. So that was a point that we made. The other big thing, and we had touched on this earlier, is this whole idea of recertification. The recertification process has to really, well, first and foremost, it has to assure the public that people are maintaining the competency level that they were originally certified in, but it also has to be meaningful to the board certified pharmacist. And so right now, the recertification activities are largely continuing education based. We're in a self-study process now as a result of this white paper to say, are there other activities that could count for recertification that would be valid and yet meaningful to the individual? So credit related to research, scholarly publications, mentoring and teaching, not exclusively any one of those things, but just a broader palette to choose from to demonstrate that you've maintained your competence. And we just think that's important because at the end, this still is largely a voluntary credential. And the process has to be meaningful to those folks. So we recognize that and made that statement in the white paper. So there are probably some of the high water marks in that paper that we'll be working on over the next 5 years. And if we can resolve those things and have some conclusions on those, I think we'll be well positioned for the future.
And I'm assuming that a copy of that report is on your website if someone...
It is. The BPS website is www.bpsweb.org, and that white paper is on there, as well as detailed information about all of the specialties, the eligibility criteria, the content outlines. It's a great resource. And actually, one of the things that we are required to maintain a very robust public communication for our accreditation, and the website makes the most sense to do it. So I do encourage individuals, if they have questions about BPS, visit the website, bpsweb.org, and there's quite a bit of information there. Hopefully you'll be able to find answers to questions that you might have.
Before I move on to your career, are there other comments that you wish to make about BPS?
Well, I want to reiterate one of the things that's really been very rewarding to our board in this work is the ability to work across the profession and to partner with other organizations to gather input within pharmacy. It's really great to be able to see that the entire profession can coalesce around an activity, around a goal, and that's been great. And I think that's important for folks to realize. Actually, sometimes the working relationship is so close that there is confusion among who BPS is and which organization is doing accrediting versus continuing education, but that's all right because it meets the goal. And our goal in board certification always was and always will be to improve patient care, because people say, well, why do I need to get board certified and what's the rationale behind this? And it's really all geared at a method to recognize expertise, skill, and experience that in the end advances patient care. Otherwise, there is no really valid reason to pursue board certification if it's not to improve patient health outcomes.
Let's drop back now and trace your career evolution. What attracted you to pharmacy as a career choice?
Well, like many of us, it kind of took a sort of a serendipitous path. I'd always been interested in science and healthcare, and originally was thinking about going to medical school. And got some high school guidance counselor advice that pharmacy, because you're going to have to do 4 years, in pharmacy's case 5, before you apply to medical school, that this would be a good way to prepare if that's what you wanted to do. And so I had applied and was accepted to Philadelphia College of Pharmacy, and that was sort of my thought process day one, freshman year. But was really, once I was there and immersed in the curriculum and began to really truly appreciate what pharmacy was about, because I didn't come from a family of pharmacists. I really didn't have a lot of experience in pharmacy. I quickly realized there was so much potential there, and really abandoned thoughts of medical education or training, because I realized what we could do in profession. The most critical juncture and the awakening for me was probably in my second or third year. While I was there, I was attending an evening meeting of the Delaware Valley Society of Hospital Pharmacists, and the speaker that night was the late Tony Sorrentino from Thomas Jefferson University, and I was affected deeply that night by his talk, and it changed my whole perspective on my career. Tony was a home infusion pharmacist at Jefferson, as I'm sure you know, and he was on patient care team, which, going back into the 80s was a pretty cool concept. It's funny now, today we talk about that, but, Tony was doing that back in the 80s, and many home health care pharmacists actually were. Probably didn't get the credit that they deserved. And he had a patient, it was a woman who had severe diabetes. It was uncontrolled, and she had developed a foot infection and ulcers, and the doctors made the decision that they needed to amputate at that point. And medically, that was probably the right decision to make, but Tony weighed in because Tony actually got to know the patient. And what he shared with us that night was that patient had a husband who was disabled from an accident at work and had a son who was mentally handicapped, and she was the primary caregiver. And Tony said, if we do this procedure and we take this woman's foot or we take this woman's leg, he said, this is going to devastate this family. And so he prevailed upon the physicians to try a more aggressive course of antibiotic therapy, resolved the patient's infection. She was able to continue to be the primary caregiver in her family. And what was the awakening for me that night was that we had a role holistically in patient care, and it went well beyond the right medication to the right patient at the right time. And this is before Hepler and Strand talked about pharmaceutical care, and we started talking about that phrase and our responsibility to patients. And it was that just really affected me and helped me realize at that point that we could do so much more. And I guess subliminally, that's sort of when I dedicated my career to helping advance the patient care role of pharmacist. I had no idea where it would lead me at the time, but I had the good fortune of telling that to Tony before he passed, that I'm really grateful for that experience and for his willingness to step up out of the box, challenge other healthcare providers, because it was the right thing to do for the patient. So that was kind of how I started off thinking one thing in medical school and ended up with a very rewarding and satisfying career in pharmacy.
So how did you decide to complete the ASHP Executive Residency, and what did that do for you?
Well, it kind of builds off of that night. So, I realized that I wanted to help try to shape the direction of the profession. And so I got involved with the student APHA at the time, and was fortunate enough working my way through the local chapter to actually serve as a national officer in student APHA. And then that's when I realized that pharmacists actually worked in associations. I guess I should have assumed that, but that hadn't really clicked with me. And I began to think that this might be a worthwhile way to help advance the profession. And it was very diverse, and it was pretty exciting. And so I found out about, through John Koster, who was a year ahead of me both in student APHA and ultimately the executive residency, that there was such a program, and applied and was fortunate enough to be selected for that program. And then, as many residents will tell you, whether they're hospital residencies or the ASHP residency, the knowledge and the skill and the mentoring that occurs during that time is just absolutely amazing. I mean, my preceptor, Mary Jo Riley, shared all kinds of information with me, spent time, was patient, taught me so many things, and to be able to interact with individuals like Joe Otis, who were there at the time, and Warren McConnell, and everyone on that staff really took an interest and helped me grow personally and professionally. And so I'm really forever indebted for that experience. People ask me, well, what did it teach you? And it's funny, it's not like you rattle off a list of these things, but what I think it really taught me, and what a lot of residencies I think teach people, is it teaches you a thought process that will carry you throughout your entire career if you really apply it. And, as a young person, it taught you how to be a professional and mature and communicate, but it really taught you a thought process. One of the things it also taught me, as a humbling lesson too, was know what you don't know. And I still rely on that today. And I see so many people at all levels of business get in trouble when they think they know something when they really don't, or they're afraid to say they don't know something. And so that was an important lesson that I learned in that process.
And your next job was as the paid staff exec for the Pennsylvania Society. Talk about what that entailed.
Oh, that was a great experience. I went from the ASHP executive residency to the Pennsylvania Society. And I don't know, I was a pretty young guy at that time, and so I guess I figured either this was going to work or I was going to have a very short-lived career in association management, and fortunately it worked out pretty well. great support staff there from the very strong health system pharmacist in Pennsylvania, Patty Keenley, Jerry Meyer, who's currently ASHP president, Steve Schaefer, another past president, just again, Herb Flack at the time, who I was replacing, who was retiring. And that was really about rolling up your sleeves. It was a small staff and helping, trying to move a profession forward and just help those pharmacists throughout the state do their jobs as best they can on a day-to-day basis. Probably the biggest issue we were dealing with during that time frame there is there was no hospital pharmacist represented on the State Board of Pharmacy. And that probably became a 4 or 5 year process to be able to try to have hospital pharmacy practice recognized at the state board level. I mean, it's kind of amazing as I sit there and say that today that was an issue, but that really was an issue at the time. And so we ultimately were successful in doing that. The other thing now today that I think back on that we dealt with some initial drug shortages, which is funny how history repeats itself, and now obviously they're much more widespread, but there were a few drug shortages that came up, and so we did what we had to do and helped identify other sources of product to make sure that our members could get what they need, and to be there to be a resource to help folks network. That was really what a lot of that was about at the state level, creating a community for people to work together. And of course, this was before social media and a lot widespread use of the internet or any of those things. So a lot of that was face-to-face phone calls, written communication, and it was important to hold together a group of practitioners in the state. And at the time, too, we needed to be there. We dealt with some horrific medication errors while we were there. I still have the clipping from the Philadelphia Daily News that says 3 babies dead, hospital pharmacy to blame, and a horrific accident. And to be able to help educate the public, because initially folks thought, well, how could pharmacists be so incompetent? And it was an opportunity to educate folks, because it wasn't as much about incompetence, because they had a pharmacy IV admixture program. What people didn't realize is there were many hospitals that didn't even have pharmacists mixing IVs. But it started to bring to light the whole issue of medication errors and safety and confusion between products. And we had the good fortune of having, the foremost expert there in Pennsylvania, and Mike Cohen in the Institute for Safe Medication Practices. And, I think that really started a discussion, and one more widely discussed, because back in those days, people didn't want to talk about medication errors. We just need to keep that quiet. And so that was really a couple of the things during that time that were pivotal, that were really exciting to be involved in.
You left after about a decade. What were your decision points about leaving?
Well, the decision to leave the Pennsylvania Society of Health System Pharmacists was driven a little bit by the opportunity that the APHA Foundation presented. Within the foundation, we had an opportunity to do practice-based research to demonstrate firsthand what pharmacists could do to improve patient care. And that was something that was always important to me, and something that was really a unique opportunity and different than what we had done, than what you were really responsible for doing in a state society. A state society, you were dealing with the legal issues and policy issues and things like that. And so this was an opportunity for me to continue to pursue improving patient care through pharmacists, but the opportunity to actually demonstrate it was very exciting. So that was probably the biggest driver. It was a hard decision to make. Tremendous relationships there within Pennsylvania, and but we think that at the time it was the right decision, and it was. I think in these kinds of positions, having folks pick up where you left off and move it to the next level is oftentimes healthy for organizations.
So contrast a foundation with APHA, because they are separate.
Yeah, so in the foundation you have to exist for philanthropic purposes. So you have to do education, research, charity work. You're not involved in government affairs, lobbying, policy development, those kinds of things. You could do education, but you don't necessarily always have to. I don't know that many foundations do, unless they're doing public education. So there's kind of a different focus. In a foundation, you're absolutely focused at the public as a nonprofit charitable organization. Within the association, your primary responsibility is to your members, even though most national associations sort of have sort of sensitivity to the public and that, but the scope of work is different. So the APHA Foundation was really set up to be the research arm for APHA. So we had a clear direction and mission there.
So far in your career, what's brought you the most satisfaction?
I think that each position that I've held has certainly had a lot of high points. I think generally the fact that if in some way I've helped contribute to expanding the role of the pharmacist and helping improve patients, then it's all been worth it. And I've been fortunate to have an opportunity, hopefully, to contribute in some small way. John Gans in the Whitney lecture summed it up best in asking the profession to step up the responsibilities, because I think he simply said, one day we're all going to be patients. And, to help craft or contribute in some small way to a healthcare system that I might be able to benefit from, my family, you, and anyone else, is sort of where I get professional satisfaction. I often joke with students and others that I practice vicariously, because I'm not practicing on a day-to-day basis. But if I can provide the support system, the structure to those practitioners to go out and do the great work that they do, then I feel good about that.
What's the most significant learning you've had from a less than desirable outcome?
I think I said earlier, sort of know what you don't know, which is tricky, to know just enough to realize you got to get some more information. And, and I think is the other thing, some of which have worked out, some of which haven't, is not being afraid to try or to fail. To me, because I've had some things that have been successful, I had some things that haven't worked out. In the foundation, we tried to launch and scale some pharmacist patient care services in a more formalized way as a business opportunity, and it didn't really materialize. But, John Gans had an interesting take on that, because he said, once you've expanded someone's mind, they can never go back again. So even though we didn't achieve our initial goal there of formalizing these services, hopefully we've expanded folks' minds, and others will come in and they'll fill that gap, and we'll look back over a period of time and say, yeah, we did make a contribution here. Maybe not as we originally intended, but we did make a contribution.
What's the best mentoring advice that you've received, and what kind of advice do you give young folks? One of the things that Joe Otis told me that I remember, and was one of the final things he said before I actually left that day I completed the residency, and it was about not getting so caught up in brush fires that you realize the forest could be burning down around you. So it was really to make sure you always maintain a big picture perspective. I mean, obviously you've got to focus on some immediate things, but, and I've really come to appreciate this, I remembered it as a resident. I didn't really get to experience it until much later, that you can be so caught up sometimes in smaller things that you can lose sight of the big picture and probably lose the opportunity to really contribute and be effective at a much larger level, because you sort of box yourself into dealing with smaller things. The book, Don't Sweat the Small Stuff. I mean, it was really along that line to make sure, particularly if you're in a leadership position, to keep a big picture vision. So that I've always held that near and dear as I've gone through and tried to step back and say, hey, am I sweating the small stuff here, or am I really continuing to think about big picture? It's pretty germane to where we're at in BPS right now, because we really do have to think big picture, not just this year, next year, 5 years, but 10, 15, 20 years. Are we doing things now that will hold up and scale and stand the test of time? So that was probably the best advice that I got. But there's a whole long list of really good advice that I got. But that's probably one that sticks out. In terms of students, it was one of the lessons that I learned, and it's one of my soapbox issues. I think today's students are so talented, and they work so hard, and they're so driven, particularly in the classroom, to get good grades, that I actually find that sometimes young people today are afraid to fail. And I try to tell them, it's one thing to be afraid to fail, but that can become like a cancer, and it can metastasize into the fear to try. And when you're afraid to try, you failed. You absolutely will fail every single time. And so that's my concern for young people, and that's general. That's not every single one, but I sense that now a little bit more with folks coming up in profession. Conservative, don't want to fail, and that's okay to be afraid to fail, but it oftentimes goes into a fear to try. And if that happens in a widespread way, we're in trouble as a profession. And so there's a lot at stake. So I want to try to make sure that to the extent that I can, that I try to snuff out that mentality among students and people entering the profession, not to be afraid to try and not to be afraid to fail. Bill, these comments have been fantastic. Thank you so much for your time.
Oh, thank you, Sarah. It's been an honor.